Physiology of Pregnancy and Prenatal Care. What we'll do today is we'll look at antepartum care overview, the physiologic changes by system with associated discomforts and solutions, and the psychosocial changes that occur in pregnancy. We will cover these by trimester. First thing you need to become very familiar with is GTPAL. Gravity is the total number of pregnancies. Term is a baby that has been carried to the beginning of the 38th week. Preterm is 20 weeks to 37 weeks. An abortion means a miscarriage or termination before 20 weeks. And living is the number of children living at the time that you interview the patient. We will practice this in great length when we're in the class for activities, so be very, very familiar with this. Also, you'll see a two-digit system used in many cases. It'll say G would be the gravity, the number of pregnancies, including the pregnant ones, or P, which stands for the number of pregnancies that have reached 20 weeks. So kind of two systems that we'll use. And we'll practice these in class, so I would encourage you to practice a little bit, or if you have questions, let us know. So we're going to talk about the estimated date of birth. Often you'll see EDB, EDD, which stands for the estimated date of delivery, or an old one that you don't see so much anymore is EDC, estimated date of confinement, which means when you have your baby. So what we'll look at when we're looking at this, we'll look at fundal height, how we use fundal height to tell our EDC, how we use ultrasound. We'll learn about Nagel's rule, once again, something very important that you need to be familiar with because you will see it again. After about 20 weeks, the uterine fundus measurement in centimeters is about 20 centimeters. Roughly correlates the number of week gestation. So in general, your fundal height should be within 2 centimeters of the number of weeks gestation when the patient has a single fetus. So let's say somebody comes in and says, hey, my due date is such and such, and you figure out, oh, they're about 20 weeks, so where would the uterus be? So you would do a fundal height and do it by that. So that's the top of the fundus. You go from the symphysis pubis to the top of the fundus in centimeters. Early ultrasound up to 14 weeks is usually performed vaginally, and the crown rump measurement is used for dating. You see two little red marks there. You can see it's a crown, the top of the head to the rump, crown rump measurement. You also use biparietal diameter as they get older after 14 weeks. You use a BPD, or biparietal diameter. The femur length and abdominal circumference are used to see what the age of the baby is. Okay, so now we're going to talk about Nagel's rule. This assumes a 28-day menstrual cycle. Not every woman has a 28-day menstrual cycle, so remember that. We'll start out with a regular 28-day menstrual cycle. Last menstrual period is minus 3 months, plus 7 days, plus 1 year. So let's say somebody had their last menstrual period on May 10th, 2016. You're going to minus 3 months. We're in February. So now it's February 10th, 2016. Add 7 days, which will make it February 17th of 2016. Now you add a year, and that would be the estimated date of birth. February 17th, 2017. I would encourage everyone to practice these and to be familiar with how to do these. You will see this again and again and again and again. We'll practice this in class as an activity also, but just remember, last menstrual period, minus 3 months, plus 7 days, plus a year. Now, if somebody routinely has a longer or shorter menstrual period, then what you're going to do, if they have a 30-day cycle, you're not only going to add 7 days, because it's a 30-day cycle, it's 2 more, you're going to add 2 more days, so you would add 9 days. If you have a shorter cycle, 26-day cycle, you'd add your 7 days, and then you'd minus 2 days to get the estimated date of birth. Once again, it's very important that you're familiar with these. We'll do activities with these, but you do need to be familiar with doing this. This here, you probably will see it on the L&D units. It's called a gestational wheel, and it's used to calculate the estimated date of birth. Sometimes wheels from various manufacturers will vary by a day or so. The wheels will also show the probable day of conception. And you have to read these, the words are very, very little. And some wheels will have fetal information such as average fetal height, average fetal length, but you'll see nurses use this a lot. So let's say somebody comes in and on this wheel you can see it says last period is March, it looks like March, I'd say 8th. So then you see, okay, well if your first day of the last menstrual period, then you would be due on December 12th. You can see the other area where it says 40 weeks. When they come in, they say, oh, I think I'm in labor, and let's say it's August 15th, you can tell they're 23 weeks. That'd be way too early to have a baby. You want babies to be what? You want them to be term, 38 weeks. So how do we diagnose pregnancy? Well, there's 3 ways we diagnose pregnancy. The first one is by the signs of pregnancy. You have presumptive signs. They can be caused by other factors and may not be proof of pregnancy. These would include amenorrhea, morning sickness, breast tenderness, fatigue, urinary frequency, quickening, breast enlargement, abdominal growth, darkening of the areola. Sometimes look at what this is called a plasma. It's kind of a mask of pregnancy. It looks kind of brown around the eyes and the nose. And then you have probable signs, which these are signs that can also be caused by something other than pregnancy, but they are probably that you're pregnant, but not always 100%. Pregnancy test, urine or blood. Of course, blood is more accurate. Uterine changes. You get softening, size, shape. The uterus starts to grow. Chadwick sign, which is a bluish cervix, and you go to do a speculum exam and see a bluish cervix. Allotment is where an examiner would be checking the woman's cervix, and they actually push up on the cervix, and you actually might feel the baby come down on it, or even an outlining of the fetus. But the absolute positive signs of pregnancy are objective signs of pregnancy that cannot be confused with a pathological state and are conclusive evidence of pregnancy. These include visualization of the fetal heart beat, visualization of the fetus with ultrasound, and fetal movement assessed by somebody other than the mother. And you guys might say, oh, everybody has a story about somebody who said they were pregnant and then they weren't, and all these stories. So we need to remember that the probable signs are many times what we base our diagnosis on, but they can be caused by other pathological things. The only absolute positive signs of pregnancy are the last 3 that I stated, which are presence of fetal heart rate, visualization of a fetus with ultrasound, and fetal movement assessed by somebody other than the pregnant woman. Trimesters of pregnancy. Well, sometimes you'll see these vary a little bit according to what source, but the first trimester is normally 1 to 13 weeks. The second trimester is normally 14 to 28 weeks. And third trimester is 29 to 40 weeks. So what is our role as nurses? Well, we need to assess the family adaptation. Not everybody is happy about being pregnant. A lot of people don't have the support they need. You need to assess, are they happy? Are they sad? Is the family supportive? Is a significant other involved? All these make a difference. Are they planning? Are they considering their finances? Do they need child care? Are they getting a breast or bottle feed? Once again, these are choices that women need to make when they have a baby. So you need to look for, assess for potential problems. Look at all the data. Need for interventions. Is there substance abuse, smoking, a need for a parenting class? These are all things that you're going to look at. Of course, we're going to structure our education. We're going to teach by trimester. We're going to teach at each visit. They're taught something about their pregnancy and what's going on. And we need to explain testing and why the testing is being done for these patients. We do education regarding maternal and fetal changes. You need to let the mom know what is normal for what's going to happen to her body and what's not. This helps alleviate a lot of their fears and concerns. You'd be surprised at how many people have just believe old wives' tales. So it's important that patients get accurate information. You're going to educate regarding self-care. Nutrition is important. Sleep, rest habits. and their needs, it will probably increase, and hygiene, hygiene is important. We'll talk about sexual counseling. They may have questions. Can they still have sex, intercourse? When do they need to stop having intercourse? Of course, that's whenever she says so, unless otherwise advised by a provider. But comfort promotion. What are they allowed to take over the counter? What aren't they allowed to take? Some OB offices will provide them a list of meds for relief, just for basic aches and pains. And normal versus abnormal signs and symptoms. For example, what if they have, what is normal nausea and vomiting, and what is not normal nausea and vomiting? So a lot of education is going to go into these patients, and they have a lot of questions, because it can be a very exciting or a very devastating time in their life. So it's important to understand what the patient needs are and do a thorough assessment. So in the initial visit, normally you do a health history. You're going to find about drug use, any family history. You're going to do a physical, a head to toe, a fetal heart rate. A provider will do a pelvic exam to assess the uterine size, pelvic capacity, and if laid into care, they'll get a fundal height. So if you're able to do a fundal height, they're later in prenatal care. An example of some of what they will do is on page 270 in your book to about page 277. They're going to look at prenatal lab work. Then prenatal labs vary depending on the provider. But they generally include an RPR, CBC, blood type and RH, antibody screen, hepatitis B surface antigen, a sickle dex, rubella titer, a pap smear, chlamydia and gonorrhea cultures, a urine culture, HIV, and various other ones depending on the provider. You need to educate them that diet and their proper diet and exercise. And of course, exercise is okay unless there's a medical contraindication. During the second trimester, they follow up about every 4 weeks till about 28 weeks. So they'll do an assessment of the fetus, assessment of the mother, labs, and preterm labor prevention education. So they're going to assess the fetus heart tones, the heart rate, it's frequently called heart tones, the fundal height. Where is the fundus at? If she's 22 weeks, it should measure 22 centimeters. They're also going to do Leopold's maneuver. And Leopold's maneuver is explained with good pictures in your book on the pages I told you to. But they're going to do Leopold's maneuver to see where the baby is, where the head is, what position is it in. And they're going to assess the mother, weight gain, is she gaining too much, is her blood pressure getting too high, edema. About 15 to 20 weeks they do maternal fetal alpha fetal protein, which in a 1 hour glucose tolerance test between 24 and 28 weeks. Of course, we do preterm prevention education and ultrasound to evaluate the fetal anatomy, and that's best done at 18 to 20 weeks. So you can see early on in pregnancies there's a lot of testing that goes on, and it's important for genetics and just to see if the baby's growing and the organs are normal, and to decide if there's any problems or anything that can be addressed or prevented later on. Or sometimes people argue about, well, why would people have this testing? I'd never do anything to my baby. I'm going to have it, and what's wrong with it? Well, some people believe that it's very good to have an idea if there's something wrong with the baby. So if there's something wrong with that baby, they can sometimes address it during pregnancy, or at least the pediatrician knows when the baby's being delivered, that we can anticipate some complications and have the correct people there in the event that something happens. I mentioned performing Leopold's maneuver. That's on page 271 to 272. It gives a very good explanation. That's kind of hard to do on when you're doing a voiceover. Third semester, they'll usually see monthly, like I said, every 4 weeks until 28 weeks, and then they're seen every 2 weeks until 36 weeks. And then after 36 weeks, they're seen weekly. Usually monthly, okay, let's see. Physical examination, pretty much the same. Blood pressure, weight gain, fetal heart tones, fundal height, presence of edema. They might do a urine dip strip. We do a urine dipstick. We also do a group beta strip. Normally about 34 to 36 weeks, depending on the provider. And other labs that might be necessary if they need to repeat it. One thing we give ROGAM if they're Rh negative, and we'll get more into that when we talk about blood. But generally, if a mother is Rh negative, they'll get ROGAM given to them at 28 weeks gestation, and then again possibly after birth, depending on the baby's blood type. So, warning signs. When should they call a provider? When they have severe nausea and vomiting and unable to retain any fluids. Some nausea and vomiting is easy. It's solved by saltine crackers, some people say. Some people say ginger cookies. Some people say ginger. But some nausea and vomiting may be normal. Cramping. Cramping, they need to come in if it's not relieved with rest or if they're having any vaginal bleeding. Fetal movement pattern changes. The moms get to know their baby's movement patterns. Normally, babies move fine, but if there's any big change in the way the baby's moving, they need to come in and be evaluated. Headaches unrelieved by Tylenol, rest, and hydration, or associated with visual changes. A lot of times you would see women get headaches, but they've been out in the heat, haven't drank water, and haven't rested all day. You tell them, hey, can you take some Tylenol and rest and see how that helps? And of course, drink lots of fluid. Edema, not just dependent edema, but they also might have facial and hand edema. That's concerning. Epigastric pain in the upper right quadrant is a sign of liver enlargement, which they need to come in and be seen if they have that problem. A gush of fluid from the vagina, and maybe urine, but the baby hitting the bladder, but it may be amniotic fluid. You can look at the fluid under the microscope, which is an old method that we've used, or you can do an amnisure test that shows for protein in the amniotic fluid. So we've mentioned weight. What is a normal weight gain? Well, you can see by this, where does the weight go? This is by the time they're term. You have a baby is 7.5 pounds, amniotic fluid is 2 pounds, placenta is 1.5 pounds, uterus is 2 pounds, breast is 2 pounds, body fluid is 4 pounds, blood is 4 pounds, and of course the mom gets stores of fat, protein, and other nutrients, and that's about 7 pounds. So average is about 30 pounds. Now look, for somebody with a normal BMI, you're going to have 25 to 35 pounds. The book says 1.1 to 4.4 pounds in the first trimester. You can just be about 5 pounds during the first trimester, and about 1 pound per week after that. If they're underweight, they can gain anywhere from 18 to 40 pounds. Overweight, of course, 15 to 25, and obese, 11 to 20. So you kind of see the little bit of difference on weight gain for what's normal BMI, what's underweight, the weight gain, what's overweight, and what's obese. So they are a little bit different. So just make sure you review those. Okay, now we're going to talk about reproductive changes. The uterus in the first trimesters is become globular and ovide rather than pear-shaped, because the uterus is normally pear-shaped. At about 8 weeks, it may have what we call a Hager sign, which is a softening of the lower uterine segment. And of course, increased endometrium and increased vascularity. They may feel some little Braxton Hicks contractions or cramps. They should not feel this on a regular basis, like every 5 minutes, but they may occasionally feel something. In the second trimester, it's normally palpable above the symphysis pubis because it's about 14 weeks. It continues to grow, and the muscular walls are, it's growing, and the patient may feel quickening about 16 to 18 weeks. And that's quickening is when you might feel the baby move. The fundus is at the umbilicus at about 20 weeks. or 20 centimeters. They may begin feeling some little contractions every once in a while, which we refer to as Braxton Hicks. Or they may have, at the uterus, they may have ligament pain, which is just down in the lower ligaments from the uterus growing and getting bigger. They have what we call ligament pain, and that's normal. But by the third trimester, the uterus is 20 times bigger than a non-pregnant size. That's with a single fetus. Blood flow through the uterus is about 500 milliliters per minute. It displaces the intestines to either side of the uterine wall. The fundus is at the xiphoid or at near term, about 38 to 38 to 40 weeks. Of course, your Braxton Hicks contractions increase in frequency and intensity. During the first trimester, breast will increase in sensitivity. Veins are more visible due to increased vascularity. Nipple may become larger or more erect, and increased pigmentation of nipples and areola. The nipples have Montgomery's glands, which may keep the nipples lubricated, so there might be a little bit, some people say, oh, my nipples are leaking, my breasts are leaking, and sometimes it's just the Montgomery's gland. During the second trimester, they may develop stretch marks on their breasts, feel nodular due to the ducts and the alveolar tissue. Estrogen and progesterone inhibit lactation, and colostrum develops. And people may say they secreted colostrum as early as 16 weeks. And of course, massaging or pulling on the nipples is not recommended. Third trimester, same as second, perhaps more stretch marks, may experience periodic leaking of colostrum. The cervix in the first trimester, you see Goodell's sign, which at 8 weeks, and it's a softening of the cervix. Non-pregnant feels like a nose, pregnant feels like an earlobe, so you can feel the difference. Then you have Chadwick's sign at 8 weeks, a provider may see, and this once again is in your book about page 271 to 278. Chadwick's sign at 8 weeks, which is a bluish color to vaginal mucosa in the cervix, so it kind of gets bluish. The cervix might be a little bit friable, which means when they have a vaginal exam, they may kind of spot a little bit, just a little bit of spotting, but not a whole lot. And of course, the mucus plug develops. During the second trimester, the mucus plug increases, and blottement with cervical exam. And that was where I was telling you that the examiner will be checking the woman, and he'll feel the kind of push up on the cervix, and he'll feel the baby come back down. Of course, the vagina and the vulva during the first trimester is going to be increased white color. Discharge may increase. Pelvic congestion, just more blood flow, and secretions may be more acidic. So you may see more women coming in complaining about more discharge. During the second trimester, external structures may enlarge due to vascularity and fat deposits. Increased sensitivity. Third trimester, increased vascularity, and may cause discomfort in the vaginal walls relax in preparation for the stretching during birth. So the body's getting ready to have the baby. Ovulation stops, of course, and what happens is the elevated estrogen and progesterone levels suppress FSH and LH. And so the ovaries help support pregnancy until 10 to 12 weeks by producing progesterone and minimal hypertrophy in the tubes. Okay, the respiratory system. So structural changes over the whole pregnancy. Diaphragm moves upwards, decreasing space for lungs. The transverse and anterior-posterior diameters of the rib cage increase. Estrogen levels cause ligament of the rib cage to relax. And they're hormone-based, and they begin to occur before the uterus begins to be large enough to take space, and may need to sleep with the head elevated a little to breathe easier as they near term. You see an increase in estrogen makes respiratory tract more vascular, so edema and hyperemia develop in nose, pharynx, larynx, trachea, and bronchia. Responses to this include stuffy nose, nosebleeds, voice changes, fullness in ears, and earaches. Functional changes over whole pregnancy. Progressive increase in tidal volume beginning in first trimester. Total of 30 to 40%. Respiratory rate may increase by 2 breaths per minute. We're going to have an increase in arterial PaO2. PaCO2 decreases from 40 millimeters to 27 to 32, allowing for transfer of CO2 from fetus to mom. And you have an increase in maternal excretion of bicarb. Increase in maternal pH. Increased risk of hyperventilation, and that's caused by progesterone. Pregnancy is a state of respiratory alkalosis, compensated by metabolic acidosis. Maternal hemoglobin has decreased affinity for O2, while fetal hemoglobin has an increased affinity for it. So a lot of complex things going on. So, pregnant women, legitimate concerns. Okay, next thing we're going to talk about is the cardiac system. The heart itself and cardiac output in the first trimester. The heart enlarges slightly. Cardiac output begins to increase due to increase in stroke volume. That's first trimester. And during the second trimester, the heart displays upward and to the left. PMI is upward and laterally about a half of an inch, about the fourth intercostal space. After 20 weeks, may hear audible split of S1 and hear S3. A grade 2 systolic murmur, which is benign, may be heard in pulmonic area. Cardiac output peaks at 30%. Some sources say 50%. Pulse increases 10 to 15 beats per minute. May have palpitations. And of course, the maternal position on cardiac output, you don't want people to be laying flat on their back because you have the aorta and they lay on that and then it decreases their cardiac output. So you want to make sure moms are kind of sleeping a little bit with maybe their head of their bed up a little bit. Of course, they're going to complain of hemorrhoids, varicosities. Dependent edema is very common and normal. And some may say they feel palpitations. They lay down, they complain of supine hypotension. That's more common in the third trimester, but it can occur early on in pregnancy. Many sources say cardiac output peaks at 32 weeks. Maternal position is even more important to cardiac output as the fetus continues to grow. 33% of additional blood volume goes to the uterus, 30% to the kidneys, and cardiac output increases with exertion, such as labor. Blood volume and pressure. First trimester blood volume starts to increase at 10 to 12 weeks. Systemic vascular resistance begins to decrease, aided by progesterone, which relaxes smooth muscle, pulse pressure, and the pulse pressure widens. Pulse pressure, like I said, widens. So that's a systolic blood pressure minus a diastolic. In second trimester, blood volume reaches a maximum of 50% over the pre-pregnant level due to peripheral dilation. So you're going to see this is important, systolic decrease in 10 to 15 millimeters of mercury below pre-pregnancy, and diastolic decreases up to 20 to 25 millimeters below pre-pregnancy rates. And that is due to peripheral dilation. Third trimester, blood volume is 25 to 45 greater than pre-pregnant. Blood volume increases to about 45%. The blood volume increases about 45%. Red cell volume increases about 20 to 30% by term. And of course that needs to in order to compensate for the blood loss from birth. And blood pressure rises toward pre-pregnant levels as they near the end of pregnancy. During the first trimester, some of the self-care is over the course of pregnancy, iron will need to increase from 300 milligrams a day to 1,000 milligrams a day. Of course, over pregnancy, coagulation factors increase. PT, PTT, and platelets remain unchanged. Second trimester, physiologic anemia occurs. You have a normally the hemoglobin is 12 to 16, and a normal hematocrit is 37 to 47. A woman is not considered anemic until hemoglobin is less than 11 or hematocrit is less than 33%. Other sources will say less than 10 or less than 35. And sometimes what you'll see is it just depends on how the provider was trained. WBCs start to increase. During the third trimester, it's the greatest need for iron for the hemoglobin production. Hard to get it just from diet. Of course, WBCs peak. Their norm is 5,000 to 12,000. Fibrin in blood has increased by 40%, and fibrolytic activity decreases, putting a woman at risk for thrombosis. The gastrointestinal system. The first trimester. Decrease in tone and motility of stomach due to the effects of progesterone. Relaxes the smooth muscles. You'll see that they have nausea and vomiting. They have increased saliva production versus decreased swallowing due to nausea. They might have hyperemia and softening of the gums. So they'll say my gums bleed when they complain that their gums might bleed when they brush their teeth. Of course, gallbladder becomes hypotonic and distended. And of course, women have heartburn. Second trimester, you're going to see usual nausea and vomiting of pregnancy. It usually is improved by 16 weeks. As the uterus moves up, the stomach is displaced upward, and the esophagus is relaxed, and they may complain of increased heartburn. Fasting residual volumes in gallbladder is doubled, and there's an increased risk for excess cholesterol or gallstone formation. In third semester, they may have a hiatal hernia may develop after the 7th or 8th month, and the intestines are displaced. Intestinal motility decreases due to progesterone. You have an increased absorption of water from the colon in combination with decreased motility causes constipation. Hemorrhoids created by dilated veins in the rectal and anal mucosa and decreased venous return, as well as uterine pressure, straining with constipation and prolonged standing. So you can see that they start to develop, why they develop hemorrhoids. And the gallbladder is still at risk for higher cholesterol and gallstones. So we talk about the first point. So appendicitis is more difficult to diagnose in pregnancy due to the relatively high prevalence of abdominal gastrointestinal discomfort, anatomic changes related to the enlarged uterus, and the physiological leukocytosis of pregnancy. Pregnant women are less likely to have a classic presentation of appendicitis than non-pregnant women. The most common symptom of appendicitis, i.e. right lower quadrant pain, occurs close to McBurney's point in the majority of pregnant women. Regardless of the stage of pregnancy. However, the location of the appendix migrates a few centimeters along with the enlarging uterus, so the third trimester pain may localize to the mid to even upper right side of the abdomen. The renal and urinary system. First trimester, as early as the 10th week, renal, pelvis, and ureters dilate. And this is once again progesterone. You can see the role progesterone plays, a big role. Bladder becomes more vascular, and that's effectively estrogen. By the 5th week, bladder irritability, having to urinate at night frequently, and urgency are common. That's not uncommon at all during the early on in pregnancy. First trimester, the RPF, the renal plasma flow, and glomerular filtration rate, GFR, increase after the 12th week. Clearance of amino acids, glucose, proteins, electrolytes, and vitamins is more rapid. BUN and uric acid decline. Renal function is best in lateral recumbent position throughout pregnancy. During the second trimester, the uterus lifts up off the bladder so frequency increases. Urethra lengthens. Bladder shape changes which decreases capacity to retain urine. Now we know why they go to the bathroom so much, don't you? Renal plasma flow and glomerular filtration continue to rise, and BUN and uric acid decline. During the third trimester, ureters continue to dilate, more on the right than left due to pressure of the displaced uterus and enlarged right ovarian vein. As the uterus grows more, having to go to the bathroom at night, I can't say this word, nocturia, frequency and urgency return. So you're going to see that they have to go more often, and this is common. You hear, can't go 30 minutes without having to go to the bathroom, some pregnant women say. The urinary stasis increases, which then puts a woman at more risk for infection, and the uterine walls lose muscle tone. The RPF and GFR continue to increase. The BUN and uric acid increase. Use of lateral recumbent position increases peripheral perfusion to the kidneys, which increases output and decreases edema. And of course, dependent edema is common in pregnancy. And dependent edema would be like your hands or your feet. You're dependent, when you're up on your feet a lot, they might say that they're swollen. Sodium, they don't limit sodium, and they don't add it. Stay the same. Common finding is to find glucose in the urine, maybe a +1 level, and if they do, they assess for gestational diabetes. Proteinuria, values of 1+ by dipstick, a urine dipstick are okay, and you'll see that. Calcium and phosphorus are excreted. There's an increased need for calcium. Don't increase phosphorus as the U.S. diet is high in phosphorus. Watch snack foods, processed meat, and carbonated drinks. Diuretics are rarely used and can cause severe hypovolemia and reduced placental perfusion, especially if combined with excessive sodium restriction. The skin. The changes will start in the first trimester and continue throughout. Linea nigra is a dark line from the umbilicus to the mons pubis. You have a couple of good pictures of these on your slides. The chlasma, the mask of pregnancy, you see, you have a picture of that mask of pregnancy, you kind of see it darkens. Some people's will turn red. You get an increased pigmentation of the nipples and areola. The perineal area and inner thighs might get a little bit darker. You might have spider nevi on the face, neck, chest, arms, and legs. They might have palmar erythema, which is their palms get red. Nail changes, some say they grow faster. Hair growth changes. Acne changes. And once again, some of this just depends on the individual, what actually happens. And everybody's different. So during the second trimester, you may get striae gravidarum on the breast, hip, aka stretch marks, thighs and abdomen. You may get raised nodules on the gums and they bleed easily, and these are called epilis. So some of the changes are pretty obvious, and once again, they depend on the individual. Stretch marks, not everyone gets stretch marks, and some women get really bad stretch marks. Like the next slide, you see these are really some good stretch marks, but not everybody gets stretch marks, and there's no rhyme or reason who gets them. Okay, throughout pregnancy, the musculoskeletal system, as a result of hormones, fetal growth, and weight gain, a backache is common as early as the first trimester. It just, once again, depends on the individual. As the uterus grows, pelvic tilts forward and lordosis results in back and shoulder strain from large breasts. So these are all things that can occur in a woman, a pregnant woman. Another thing we talked about, it's on the last slide, is called a diastasis recti. And this is where the abdominal wall kind of pulls apart. You can kind of see this. And you can kind of see these are good demonstrations, a normal one and an abnormal one. So you can kind of see how it pulls apart, and you can kind of see the uterus kind of comes through. And not in a bad, and they may have this, and usually after pregnancy it might not be as pronounced, but over time some women's will go away and some will never go away. But it just depends on the individual. Now we're going to look at psychosocial changes. Just remember, every pregnancy is different to every family. And the way we think we should feel about pregnancy may not be the way they feel. Every family dynamics, every family situation is unique. So we must remember that all the psychosocial changes that go on, this is part of your assessment of the patient, and not to be judgmental. Maternal, during the first trimester, incorporation and integration of the fetus as an integral part of the woman. She needs to accept that I am pregnant. I have this baby inside of me. Some women don't want to be pregnant, or they really don't care that they're pregnant, and they kind of deny it. So you want to realize that 50% of pregnancies are unintended. So you may not see them real happy at first. They may be shocked. They may be like, oh my gosh, what did I do? I'm not ready for this. So there's all sorts of emotions. That doesn't mean that's how they feel their whole pregnancy. But that means that's how they feel at that time. And to validate that it's normal to be shocked, and we're here for you, here's what I'm going to do. But your big task that you want them to be able to say is you want them to say, I am pregnant. You want them to accept it eventually, as the pregnancy moves on. Sometimes you'll see in the first trimester, they're the primary focus. The baby's not perceived as a reality. It's kind of not perceived as a separate object. It's just there. Interest and concern about their bodily and emotional changes. So these are primary focuses for some pregnant women. They can't believe the mood changes. Sometimes their perception of the fetus is vague. But these are all normal feelings during pregnancy. So just remember the psychological task is they need to be able to say, I am pregnant. And sometimes it takes a while for women. Some women, whatever their situation is, career women, or, maybe somebody's just not ready to have a baby and they end up pregnant. So there's all sorts of things that go into a lot of psychosocial and OB. In the second trimester, you'll find that the fetus is a primary focus. They see fetus as a separate object and not as an extension of themselves. Some may have names for the baby. They may picture the fetus as the newborn infant. They may assign their own sex and describe it with specific characteristics, or they may find out the sex and say, oh, this is a boy. Some may hope, and just wait till the end of the pregnancy. So they want them to be able to say their psychosocial pregnancy adaptation is, I'm going to have a baby. Pregnancy becomes real with a growing uterus and fetal movement. During the first trimester, remember, women just don't feel real well in a lot of cases. But they get excited when they start to feel their baby move, and they have a heightened interest in their diet and fetal development and information. And they're concerned with the ability to care and protect the fetus. They examine, they kind of have a relationship with the fetus. And a relationship, they may say, oh, here's your grandma, and they're pregnant, and they're like 20 weeks, 25 weeks. So they actually start to assign relationships. Some just daydream about the infant. So it just kind of varies. Of course, narcissism and introversion wants to do the right thing to protect herself and her baby. Body image rapidly changes. Breast, abdomen, pigmentation, etc. Altered function because they lose their balance a little bit. Maybe their physical endurance isn't as much. They have some discomfort. It can be viewed as negative or positive. Sexuality changes increase. The same. Some may decrease, some may increase. It just depends on the individual. Um, of course, culture may have an influence on this. All right, they have the freedom from worry about becoming pregnant, which is a big deal to some people, and increased labor and clitoral sensitivity, creative positions. They may ask for, they may be willing to try creative positions, and they worry about harming the fetus, and that's especially with men. But they don't need to worry about harming the fetus as long as they follow their provider's guidance. Once again, the psychological cast, they need to be able to say, I'm going to have a baby. Changes in sexuality. During the first trimester, they may have nausea, fatigue, fear of miscarriage, and these may all interfere with the sexual feelings. During the second trimester, of course, they don't have to worry about getting pregnant, so they might enjoy sex more, and they might even have increased sexual responsiveness, as I said on the earlier slide. Third trimester, because the belly's big, they may suggest they may ask, how can I have intercourse with my significant other, and can suggest alternate positions for sex. And of course, sexual response varies widely. There are no two alike, so each woman may feel comfortable asking her questions. Some may be very, very open, and others may be very conservative about speaking of sexual intercourse. During the third trimester, they worry about the baby maybe lost or harmed. Vulnerability is what they worry about. They're increasing dependence. You'll see that they're willing to accept people's help more. They kind of, might not want to go alone to some things that they used to go alone to, or go places by themselves. The maternal psychological pregnancy adaptation in third trimester is to be able to say, I'm going to be a mother, or I'm going to be a parent. Of course, they have nightmares about protecting because they want to protect their baby. They need reassurance from the partner. And there's a lot of mixed emotions during the third trimester. They're anxious for the upcoming labor and birth, yet they're scared. They don't know if they're ready for labor. They've listened to everybody's horror stories. And so it's just a whole emotional time. Of course, they should be planning the baby's arrival at home. They need to decide on a method of feeding, breast or bottle feeding. Once again, that's a personal choice. Acceptance of demands that the baby will make on parents, that, becoming a parent isn't a picnic, but that there's certain demands that the baby will have. They need to be more confident in their knowledge about labor and delivery, so this might be a time that they're looking for more education. Oh, should I go to a class? Should I do this? And of course, they may be interested in child care if they're going to need it, or planning for the future. Okay, so here's some steps in the maternal rule taking. They try on the pregnant and mothering role. They observe, they cope. They're observing, they're copying, they're looking at what other people are doing, kind of mimicking them. They role play, they act out in practice. Maybe they might say, "Oh, I want to practice taking care of your baby," and you need to be very, sensitive to the partner and mother's response to this whole pregnancy. Fantasy daydream is they try on boy or girl, dark or light. They start talking about what kind of baby will they have. Blue eyes, brown eyes. They might like activities with an infant or a child, and they'll talk a lot about dreams. A lot of women have a lot of dreams about their baby and what their baby's going to be. What's it going to look like? What's it going to do? They have all sorts of dreams. It's kind of interesting. Okay, I think I'm skipping a slide because my slides are out of order. So we're going to talk about maternal tasks of pregnancy. First of all, they're gonna seeking safe passage. They seek health care, follow recommendations, diet, vitamins, avoid harmful food and substances. You might find some that'll quit smoking. Some will cut back. Some will go on these really healthy diets, and not diet per se, but healthy. They'll eat healthy foods. They'll stop eating junk food. Sometimes they'll cut back on harmful substances. They adhere to cultural practices. They talk a lot to their moms or partners, what they culturally learned about having babies. They kind of look for acceptance as a mother. the partner has to be willing to change from an exclusive relationship to now a relationship where they share. And for some partners, this is kind of hard because they are not the number one anymore. They kind of want people to, they watch how people react to their pregnancy announcement. Are they happy? Are they upset about it? So they like people to be happy. That helps them accept it. That, to include family members. And they might start to increase the closeness to their mother. They may feel like the woman may become closer to her mother because she starts to ask her more questions. And of course, unconditional acceptance of infant, a boy or girl. And you'll see these are tasks that they go through. Because somebody will say, I really, really, really just want a girl. And they find out they have a boy, and they're like, I'm just really happy I'm having a boy. I mean, it's just, they're going to love whatever baby they get. And of course, they worry about physical anomalies or what's going on with their baby. Another maternal task of pregnancy is learning to give of herself. Of course, her body's nurturing the growing fetus. Acts of kindness to family and friends. You might see they kind of change their whole outlook on life. They'll make lifestyle changes to accommodate the new baby. They may have baby showers to confirm interest and commitment of family and friends. So they want to see people involved. When we talk about making lifestyle changes to accommodate the new baby, you'll see someone will say, well, I don't think I need that in my career anymore, or, well, I think I'm going to change this, or I'm only going to do this. So they're going through the acceptance phase and kind of just some of the tasks of pregnancy. Well, I just talked about that slide. Okay, so the next one is committing herself to the unknown child. During the first semester, you'll see that they accept pregnancy. And sometimes it'll take a little bit, but they'll accept pregnancy, normally. The second trimester, it's attachment. The baby is real, I can feel it move, here's some pictures of it. I've seen people bring out like 3 feet of ultrasound pictures because they have a relative that works at the x-ray, and they've taken all these pictures. I mean, people are very excited about their baby. Third trimester, they describe unique characteristics of their babies. They may talk about the sleep-wake cycle, the movements, how they sing to their baby, how they talk to their baby, how their baby responds when they sing to them, and how they communicate with their baby. You might see a mom or dad talking to their baby. Readiness for fatherhood is more likely there's a stable relationship between partners. Sometimes the dads will feel left out or feel like they're not being part of it. So if they're coming to appointments, we need to make sure we include them. And it may be more difficult for males to adapt to the role of father because they're often neglected when the focus is on the woman. They start to feel bad, like all they care about is her. Is she happy? How does she feel? What's she doing? What's going? And so sometimes they feel left out when it's not. The focus is just on her. And of course, dads need the same support as the woman does, or the father of the baby does. Need support as a woman does. So we need to make sure we're giving the whole family. And these are things to be sensitive to as you watch people in your lives that have babies. You can kind of see it. They need to feel included. Okay, so sometimes part of parental adaptation is reality of pregnancy and child. Like I said earlier, sometimes they're ambivalent at first. Sometimes reality boosters are fetal heart tones, where you hear the baby's heartbeat, ultrasound, where they see the baby, or they might start feeling the baby and be like, wow, this is real. Sometimes they struggle for recognition as a parent. They need to feel validated. Men need to feel like they are part of the process. Childbirth classes are good, where they can talk to other men. Sometimes they actually have a daddy boot camp here in San Antonio that is taught by a male labor and delivery nurse, and you see that they just being with other men and learning about this stuff and talking about it because it's all reality. But some dads, they don't feel involved at first, kind of like the mom, ambivalent, whatever. But once they start to be part of it and hear the baby's heartbeat and see the ultrasound, they get to feel where they're part of it. Of course, parents need to talk about who's going to feed the baby, who's going to change diapers, nighttime care. Are you going to divide up duties, or is mom primarily responsible? So these are individual choices, and every couple of days, the mom's breastfeeding. She may, they say, I'm going to feed the baby, but you can change diapers, nighttime care. they can switch on and off. But this is how they have to talk about their roles. And of course, some of these roles will be based off culture. Some of them are culturally driven, and it's just something we have to accept. The role of the involved father would be, they kind of try on behaviors like, well, reflection of self, how am I dealing with this? They, talking to the mom, interacting with her, calling him dad, you know what I mean? They want to feel like they're part of the process. They like parenting information. Sometimes men will feel pregnancy symptoms. Some men will tell you, I gained 20 pounds when my wife was pregnant, and some will tell you, I've had one tell me that they had nausea and vomiting their whole pregnancy. So each one is going to be individual and different, but that's just part of the process. Like I said, just part of being a parent and listening to them talk about their role and adapting. And of course, cultural roles are very, very, very important when it comes to parenting. Sibling adaptation. Toddlers less than 2 years old, they're unaware that mom's pregnant, unaware of new baby. Some of them are jealous, resentment, anger. They don't want you holding the baby. They want the attention. So what you do is the parents are encouraged to establish new sleeping arrangement several weeks prior to birth. So if the 2-year-old is still sleeping in the room, in their bedroom, maybe they need to move them to their own big girl room or big boy room. I remember one of my daughter, my oldest one, tried to drown her baby doll when I was feeding my youngest one, and she was jealous. So now we laugh about that. But at the time, you have to acknowledge that, hey, she wasn't happy about this baby coming in, interfering in her life. But you always reassure them with lots of love and affection. Older children, 3 to 12, are aware of maternal changes, look, feel, listen. They have lots of questions. Of course, they want the newborn to be an instant playmate, and that's not going to happen. But so they're kind of disciplined about that, and they want to feel important. They want to be prepared in preparation. In preparations for the baby. They want to talk about the baby. Some organizations have sibling classes that are very good for them. So you want to include a 3 to 12-year-old. They generally want to feel important, a big brother or big sister. Adolescents, of course, it will depend on their developmental level. Of course, they're just immersed in their own developmental tasks. They're busy trying to become adults themselves. They're embarrassed. Their parents actually had sex. Or they may be indifferent or very involved. Once again, depends on the developmental level, what's going on, where they're at, how their parents have, the communication within the family, things like that. But some may be indifferent and some may be very involved. You find every variety. Of course, we always talk about culture. Culture is very, very important. I think the big thing is not to judge people for their beliefs. We need to be open and respectful of other cultural beliefs that are different than ours. It doesn't necessarily make them wrong. They're different. And I think it's, especially in childbearing, some people will say, well, I don't know why they're doing X, Y, or Z, or I don't understand why they're doing X, Y, or Z. It's important to get to understand the different cultures and what they do that's been a little bit different. Of course, nurses need to ask, like, well, you can ask all sorts of questions, like, what concerns do you have, or what do you want to do for this? What is your desire for this childbirth experience? Or when you're taking care of the baby, tell me what you want me to help you with, and you don't want me to help you with. Or some cultures you'll find where the mom doesn't take care of the baby at all, and the mother or the father will be there the whole time taking care of the baby. So, of course, you always ask, no stereotyping, avoid violating cultural norms, and that's where it's important to understand the patients that you have. Of course, there's beliefs regarding hot and cold, wet and dry, the evil eye. It's important to have interpreters, and it's important to communicate with interpreters. If you're talking medical things, there are interpreter phone lines that you can get on, and the interpreter is a medical person interpreting. One thing that I found with a lot of my students is they may be fluent in Spanish, but they don't know the Spanish word for the medical diagnosis that they're giving them in English. So it's very important to have medical interpreters. Talk to them about like time orientation. You know, some cultures really aren't worried about time, or they're constantly late, or something else comes up that's more important, and they miss their appointments. And some of this is cultural. So, and each culture is unique. I've been a nurse for a long time, and I learned more about several cultures in the last year than I ever knew. So you're constantly learning. You're never going to be 100% culturally competent, but you can become when you start to ask questions and learn about them. It's important to be open and learn. So here's what concerns do you have about labor? Cultures vary in their labor practices. Pain relief. There's some cultures that are very stoic, that do not believe in pain relief. They say, no, I'll be fine. Just leave me alone. I don't want pain relief. Or who do they want with them in labor? Some people want their healers. Some people want a different person. Some people want their mom. So each culture is different. Negotiate. So this is really important, to find mutually acceptable options. Find what works, that's safe, that doesn't cause harm to the patient or the baby, but come to mutual acceptable options. Talk to them and develop a plan together. And you can collaborate with the woman, family, and community resources. There are quite a few community resources out here we have so many cultures. I can't even list them all that you'll see and that you'll experience. But it's important that you understand that there's people out there to help us to understand some of the cultural differences. And if you ask, they'll talk to you and tell you what their differences are. It's important that you talk to the patient. So we've come to the end of this. One thing I want to comment on is I would be very familiar with Nagel's rule, GT-PAL, and the changes that occur during each trimester of pregnancy. I know it's a lot of information, but I think it's good that you practice it. Don't be afraid of it. No normals and abnormals that go on with the body. And if you have any questions, please feel free to let me know. Thank you.